All right. I think we're probably up and running. And I'm sure people will be coming in as they cross the slowest crosswalk in San Francisco. But welcome to this second of our Emerging Scholars Exchange Program visitor from University of Pennsylvania. For those of you who are not familiar with this program, this is with the Leonard Davis Institute at University of Pennsylvania, and also with the Institute for Health Policy and Innovation at University of Michigan, which are organizations that share a very similar mission as IHPS in bringing together people from across their campuses who are interested in health services and policy research. So I think Penn LDI can claim that they're a little older than we are as the first health policy institute founded at any university, but we are the oldest one founded at a academic health campus. So there we go. So we both claim that we're the first in our own little niches. We are super happy to have Charlie Woods Hill here. Charlotte, but she goes by Charlie. She is a physician and assistant professor of anesthesiology and critical care at the Hospital of the University of Pennsylvania and at CHOP in Philadelphia. If you see her slide, you can see that there are a lot of affiliations that she does, which is, I think, what happens with good interdisciplinary and interprofessional and impactful research is you end up developing a lot of relationships. She is no exception. And a lot of her research is really at this intersection of healthcare resource utilization, diagnostic stewardship, which is a very pertinent and ongoing issue, and implementation science. As it relates to preventable pediatric patient harm and pediatric patient safety. One of her major projects is being the primary co-investigator of the Bright Star Collaborative, which I had heard of before today, which is an ongoing multi-center project that's studying the impact of diagnostic stewardship strategies on antibiotic use in critically ill children. There are a number of other projects that she's involved with. She's been funded by National Institutes on Health, by ARC, by foundations, and also by the CHOP Microbiome Center, and is an implementation science mentor as well at Penn. So I could keep going on, but I won't because I want to hear her presentation. So welcome. Thank you for coming to visit.
Hi, everybody. Thank you so much. I am so excited to be here. I've been looking forward to it for months. Thank you for blessing me with some sunshine, which we have not had on the East Coast. Yes, and what I'm going to talk about is maybe not what you would expect to hear from a pediatric intensivist, which is feelings. We're going to talk about a little bit of qualitative work, but concepts like fear and uncertainty, and how some of those might drive testing behavior specifically related to sepsis. And then some things like implementation in behavioral science and how we might be able to leverage those to help make better diagnostic decisions. This one. This one. Hang on. There we go. I have nothing to disclose. This is just some of the funding for the work. All right. And so sometimes I think you could sort of like slice me into three parts. And those three parts are diagnostic stewardship, which I have been lucky enough to be doing since fellowship back at Hopkins. And I'm going to spend a lot of time, actually most of my time, talking about diagnostic stewardship. But I also did get a degree in health policy research in my early days at Penn. And I do think that there is clearly an overlap between things like diagnostic stewardship and the impact potentially that overtesting has on a health system and with policy implications. And then finally, the third thing, which I find a lot of joy in doing, I'm calling methodologic adventures in the service of implementation science, stewardship, and health policy, because what really, I think the umbrella for me that is over these three sort of more specific areas is implementation science, which I was lucky enough to stumble into when I did that master's program several years ago, and has now, I think, given me really interesting methodologic tools to apply to all kinds of different content areas. But what I will be focusing on for this mostly is the diagnostic stewardship angle. So 4 objectives. One is to talk a little bit about the concept of medical overuse in general. You probably are all very familiar with this, but how it can harm our patients, particularly kids. Discuss some of the challenges, but also unique opportunities of trying to do something like apply diagnostic stewardship principles at the intersection of blood culture practices, which sounds like something super simple, and sepsis paradigms, which is really not simple at all, and how we did that during this thing called the Bright Star Collaborative. I'll talk about our consensus recommendations for blood culture use, and then sort of the main results of that project. And then finally, I think the most fun part for me is this last bit, which is exploring the integration of implementation science and behavioral science into the Bright Star Collaborative's next steps. All right, so first, overuse, super simple definition, right? It's provision of healthcare for which the net benefits do not exceed the harms. Overtreatment is a particular subtype of overuse where we subject our patients to treatment that either, according to sound science or maybe the patient's own preferences, doesn't actually benefit that person. This is a big proportion of overuse. It's very expensive. It's hundreds of billions of dollars. It's probably more now. But more importantly, potentially, is the association with worse patient outcomes and death. And unfortunately, I think we come by this really honestly, but we are part of the problem, right? I think as clinicians, we like to do things for our patients, right? We like to provide care. We want to intervene, and we feel good about doing that. But we certainly can overestimate the benefits of those interventions for our patients and underestimate the harms of what we're doing. In pediatrics, so I think we are like a bit behind our adult colleagues in kind of understanding how important this topic this is and how much of a problem it can be for kids, but we're getting better. So I'm just highlighting some of these very, very well done. I did not write these papers. I just think they're very good. These are papers on pediatric medical overuse and JAMA Peds and then hospital in pediatrics have sort of done these on like an every other year basis. And they talk about all kinds of different topics for pediatric care. Fluid use and imaging and all kinds of things. So we're sort of paying a little bit more attention to this. But what about sepsis? Is there an overuse problem potentially in sepsis? So pediatric sepsis in the context of overuse, again, I think there's a lot that's like really messy and difficult here, but a lot of opportunities to make improvements. And so I don't know if there are any pediatricians floating around here, but this is a really common diagnosis for us. This is something that's like bread and butter. It is expensive. We spend about a fifth of the money that we spend on pediatric hospitalizations every year is related to the care for sepsis. It's not uncommon, right? 8-10% prevalence in hospitalized children with a very high mortality rate, even in well-resourced places. So this is a big, big problem for us. Terminology, well, please. So this is something that we've been wrestling with for quite a while, as have the adults. So this, I think you can't hear a peds intensivist talk about sepsis without talking about this very new paper, which again, I didn't write, but I think is very important. This is the Phoenix sepsis criteria, which just landed at our big critical care medicine conference. And this is a big deal paper. They used a lot of methodologic rigor. They used 3 million sort of healthcare encounters, a lot of big data. They did a consensus process. It took them quite a long time to try to develop criteria for pediatric sepsis and septic shock, which we were mostly just kind of like using the adult definitions and sort of all acknowledging this is imperfect. We're actually not sure. Like, do I think sepsis is the same thing as you, is the same thing as this colleague? So what is it? Okay. And so very briefly, so this is the definition. It's 2 points in this thing called the Phoenix sepsis score. Dysfunction in some organ systems, cool. Septic shock is at least a cardiovascular point in the sepsis score, also great. Mortality, so what they really wanted the scoring system to do is discriminate mortality, and it did that very, very well. So if you had this 2-point score, you had a mortality of about 7%. In good high resource settings, about 28% in low resource settings, more than 8 times that of children that didn't meet that criteria. And then septic shock also tracked very nicely with mortality rates of about 11 and 33%, depending on the resource setting. Okay, so like this is great. This is really helpful. We need this. But okay, here's this great figure in this paper. Here's the top bullet. You still have to do the first part by yourself, which is you have to identify an unwell child and have a suspicion for infection, right? So this cool paper with all of its 3 million points of data still actually is not a screening system. It is not a tool that tells you who has sepsis, right? It tells you what their mortality rate may be if they have some of these things in the scoring systems, but it still actually doesn't tell you who it is. That's really important for my work because sort of like the clinical decision-making of figuring out who am I actually worried about, who may have sepsis, and conversely, who am I not worried about? Who is not infected? And who can I potentially do less things for? Still requires clinician judgment. Okay. So what do we do for sepsis? Again, anybody who takes care, honestly, of any patients will probably resonate with this, but so we go fast, right? This is what we've been told. Don't miss it. Don't ever be wrong. Go fast, right? Very helpful messaging. But there's a good reason behind this, right? So we do know that early recognition and initiation of appropriate antibiotics does improve outcomes. Conversely, delayed initiation of appropriate antibiotics will increase morbidity and mortality. All the guidelines that certainly I've ever practiced with in training and now sort of say go fast, right? Urgent attention on rapid recognition and diagnosis of sepsis. And there are high-profile national collaboratives that are really emphasizing this as well. So CHA's IPSO project, which is kind of winding down, but has been looking at for several years now at trying to sort of collect data from a whole bunch of children's hospitals. How quickly do you get your antibiotics in? How quickly do you get your fluid boluses in? And try to benchmark against each other, right? Saying, if we understand how our peer institutions are performing, how can we all improve, right? And trying to sort of meet these very time-bound metrics, okay? But are we going too fast? Certainly, antibiotics are associated with adverse drug events, drug toxicity, driving up length of stay and cost. But perhaps most importantly, antibiotic overuse is a key driver of antibiotic resistance, which is something that no matter what your sort of clinical care area is, you're going to have to reconcile with at some point. All right. And so I like the language in a couple of these. These are like a few years old at this point, but I think the messaging is really sound. So we're kind of beginning to get a little bit better about recognizing this too, right? I love this one because it says sepsis is medicine's last remaining preserve for unrestrained antibiotic prescribing, which is like, you're sort of like, I'm ashamed, but yes, that's true. And then I love this one, sepsis hysteria, excess hype and unrealistic expectations from the Lancet. And this paper was nice because it really calls for this balanced strategy, right? So what we really do need to do is reduce excessive inappropriate antibiotic use and the risks there of resistance and toxicity, okay? In children, and I'm including this just because I still think it was important. This was a 2018 paper, so before the new sort of Phoenix criteria where we're trying to like harmonize around language and definitions that we can all agree on maybe. But this talked about, this is a hard spot for clinicians to be in, right? So what are we supposed to do? You're supposed to recognize and treat patients at risk for sepsis or septic shock before they actually have the organ dysfunction, right? So that like their outcome is better. Cool. And it talks about how accurate early identification, though, of patients at risk is also important to avoid overtreatment, right? So even in 2018, we were like kind of starting to acknowledge like this is a problem. Go fast, don't ever be wrong, don't miss it. Lots of meropenem for everybody, but also maybe don't actually do that too much if they aren't sick. Okay. The PICU. So this is my clinical setting. And sadly, we contribute a lot, I think, of overuse. It is true, I will say, a lot of antibiotic overuse in the pediatric world is outpatient use, but for the inpatient setting, this is a big deal. So this was a very nicely done 10-site point prevalence study by one of my colleagues at CHOP. Over half of PICU patients kind of at any given time are receiving broad spectrum antibiotics. And they developed kind of an adjudication criteria, right? So are these antibiotics appropriate or inappropriate as much as people can tell in each of these 10 sites? Over a third were inappropriate when reviewed. And the number one category that was evaluated inappropriate was for, quote, empiric therapy for suspected bacterial infection without sepsis or septic shock, which I think means a kid in the PICU had a fever, right? Right. So this is a really important category, I think, an opportunity for having some conversations about doing less and tackling overuse. We hope so. Last couple things. I think that sort of let us know that we're trying to find the balance a little bit better with this. Again, IPSO, that collaborative that I mentioned, has developed kind of 5 key processes that it sort of suggests are important for reducing mortality. I'm not going to touch most of them, but I just want to, the one in bold is a sepsis huddle, right? So this is very common now in most children's hospitals. So there might be an EMR-based alert that goes off or a series of vital signs and clinical deterioration scoring systems that like gets you into the red zone or whatever it is. And then you'll go to have a sepsis huddle. And a sepsis huddle it's a great opportunity to sort of say, yes, maybe this kid looks terrible and like I'm super worried and we need to like do all of these things, right? Fluids and antibiotics and maybe an ICU transfer. But it's also an opportunity to like maybe make a different decision, right? And say, this child has a fever. they have a viral infection, the same viral infection that they were admitted with yesterday. And I am not concerned actually about sepsis. I've come to the bedside, I've done an evaluation, I've talked to my nurse, I've looked at clinical data, we've had our huddle, and maybe my decision is actually that I don't escalate things. The other point here is in the 2020 update for the Surviving Sepsis Campaign guidelines for kids, they made this like, it sort of like subtle and buried, but I think very important distinction in terms of the recommendations for timing of getting antibiotics in. So 1 hour still seems to really matter in terms of morbidity and mortality for kids with septic shock, right? And now we're sort of coalescing that septic shock is like this point system with cardiovascular dysfunction, right? But there was no difference up to 3 hours in children that had sepsis-associated other organ dysfunction, but no shock. And I think there's a huge difference in terms of how thoughtful you might be in with a 3-hour clock ticking above your head as opposed to a 1-hour clock. So again, just like little things that I think are indicating that the pendulum is sort of swinging back the other direction. All right, so next concept, and so this is where the diagnostic stewardship sort of mindset kind of comes in. Again, very broadly, I'm sure you guys all know what this is, but essentially the appropriate use of diagnostic testing to guide patient management, including treatment, to optimize clinical outcomes. I had the opportunity recently to write a little bit of a piece on diagnostic stewardship in the PICU, right? Like how do you sort of do this in this particular care setting with a colleague from Hopkins. And we sort of came up with kind of these like 3 questions for diagnostic stewardship, right? I focused entirely on the first bullet point, which is, does the patient actually have signs or symptoms of an infectious process, right? Do I need to send this test? What is the pretest probability of that this child actually has an infection? And will this result impact management, right? These are the kinds of questions that we probably should be asking ourselves more than we do. The second bullets are also very important parts of stewardship that are being tackled, I think, by lots of people in important ways, but our work focuses really on this first piece. So does this patient actually have an infection? All right, so here we are again. So now all these kind of concepts are swirling around. Sepsis in children, is there a balance, right? So is there an opportunity, begin to wonder, for diagnostic stewardship that lets you treat sepsis in a timely way, right, when you're actually worried about it, but allows you to safely reduce tests and treatments when your suspicion of sepsis is low? And that is what this Bright Star project has been trying to do. And so this is the team. I have to say thank you to these wonderful human beings. Erin Millstone's my primary mentor and has been for quite a while. We were lucky enough to have like incredible experts like Marlene Miller, a human factors engineer, which lets us do like sort of like interesting conceptual stuff. All of these people are still part of the team, which is great. So very, very humble beginnings. This was actually my like fellowship project back in Hopkins. Single center, purely quality improvement at this stage. So like many places, we had a terrible run of central line associated bloodstream infections in the Hopkins PICU, right? Everybody's really grumpy. The metrics are terrible. Like, what are we going to do? And so we said, okay, let's just sort of like, we'll do a multidisciplinary team review. What are the things we think are contributing to bloodstream infections in our PICU right now? Separate from this for a second, like this, yes, there's like line care and bundle maintenance and all sort of like those things that that factor into it. But what stood out when we did this was that we had a ridiculous amount of variability in how we were sending this test, right? We realized there was like one kid that I'll always remember that got like 40 blood cultures in 25 days or something, right? Like he had autonomic dysfunction, right? He had a fever essentially every day and he had a line in because he had respiratory failure. So he had a central line and people just sent culture after culture after culture, all of his lumens, right? So he needed multiple transfusions, which was also not great. And then of course, like some bug is going to grow at some point, right? So he got called CLABSy 3 or 4 times with like these things that weren't even clear that were like actually clinically informative or real. And so we were like, this is kind of ridiculous. And we realized that people's sort of threshold for sending a culture was all over the place, the sources they would choose, how frequently they would repeat it. And so we said, okay, like we can probably do better than this, right? And so we sort of sat with ID and said, let's try to standardize our approach to blood cultures, right? It's like such a simple test, you don't even think about it, honestly, but we've never really tried to standardize how we use it. So we developed these 2 very, very simple documents. It was a checklist and an algorithm. And the checklist was like, hey guys, like there might be some non-infectious reasons for fever. Please just think about them. Don't forget the infectious ones too, right? And risk factors, right? Are you talking about an oncology patient? Is this a cardiac kid with open chest? Like different sort of things. Just like please work through this checklist and then a decision algorithm paired with it. And so at that point we had two questions. So, is it possible, right, to sort of use diagnostic stewardship when you're talking about something as sort of like scary to people as bloodstream infections, right? This does kill kids. Don't miss it. Is it safe? Can we really do it? So we found a 46% reduction in total blood cultures when we did this after a year, which we thought was sort of a shocking number. A big drop in the proportion that came from central lines, which is something else we were trying to work on. And then we did look at some safety balancing metrics, right? So, because nobody's going to care, right, if you reduce the use of a test, if there's a really concerning signal that there's a sort of a bad consequence of this, like a bunch of missed or delayed diagnosis of sepsis. We didn't see any of those things. We also importantly didn't see any increase in the use of broad spectrum antibiotics without blood cultures, because we didn't want people to say like, yeah, like I'll use your thing and I won't send the test, but like I'm gonna just give this kid cefepime anyway because I think that I want to. We didn't want that very sort of inappropriate response either. And we didn't see any of that. So we thought that that was great. This was that first paper. You can see this big drop and this nice sort of sustained steady decrease in the rate of blood cultures. And so we were like, well, that was like fun and sort of went better than we thought it was going to. Can we do it again in like a couple different places, right? We did a single center, like, let's try again. So we enrolled 3 more units, one at UVA and 2 down at the Johns Hopkins All Children's Center down in Florida, and saw something pretty similar. Honestly, it was a 32% decrease across the 3 units that enrolled. And we spent a little bit of time with those 3 sites actually thinking more about the how we do this. How are we actually, like, what's working? What about the messaging seems to be like getting traction with people? And that is what led us to get the funding for Brightstar. So Brightstar was an R18. The name changed to like a bunch of the acronym did change, but so testing stewardship to reduce antibiotic use and resistance is what it is. And these were our 14 sites. So we got so lucky with just incredibly engaged collaborators sort of across the country who are willing to work on this with us. And we had 2 questions at this point. One is that we hadn't been able to actually answer, right, like the like big outstanding question, which is, okay, if people are sending fewer blood cultures, does that actually have, in a good way, a downstream impact on antibiotic use, right? Are they potentially starting fewer rounds of vancomycin if we're sending fewer blood cultures? And then how can we scale up the program? This sort of seems to be going well and is kind of like raising people, sort of like a bunch of interesting questions. Can we figure out how to like make this thing keep growing? So this is just a 50,000-foot view of what we did in Brightstar. A lot of this still at this point is like a lot of QI, right? So there's stakeholder engagement and there's develop a clinical tool. I will say very, because I think it is important and different a little bit than where the phase we are in now. So we had 14 sites who had 14 different clinical approaches. So we didn't say, hey, we think we know exactly what you should do with blood cultures. Here's like this tablet from on high. Please do this exact thing. We said, please, all your patient populations are going to be a little bit different. The opinions of your stakeholders are going to be a little bit different. So figure out what works for you. We helped them through that process, but 14 sort of different approaches. All of them, of course, had to sort of have the same general goals, which was, number 1, if anybody actually has clinical suspicion of sepsis, exit the pathway. This is not for you. And 2, to standardize the approach to blood cultures and try to reduce when possible. And so we did kind of all of these steps. Happily, we did collect a ton of like what ended up being like really rich kind of process data later. So we had quarterly, we call them kind of like our implementation survey calls, where we assessed with the help of our human factors engineer, kind of like elements about the system that they were in that would help us kind of understand the QI process later. They kept like site diaries. We did keep records of sort of all the clinical tools and the adjustments that they made. So we ended up with like a lot of good stuff that we could go back and dig into later when we were trying to figure out how people did things. Tracked data and sort of moved on through the process, and it took us a few years. Okay, so at this point, what had become clear to me in a really nice way is that, okay, so we're tackling overuse, interested in stewardship, maybe this will have an impact on antibiotics, like that's great. What this is really about though, is about how do you facilitate behavior change around diagnostic decision-making in a place like the PICU, right? Which is a complex, fast-moving environment. How do you change a PICU clinician's mind, right? How do you change how they use a test? And how do you do that when there's a lot of clinical uncertainty about the things they're testing for, right? You don't know, right? When that kid has a fever, you might, all your years of experience and your clinical judgment, you might say like, you know, I'm super like, this is the kid that absolutely is going to have this kid has E. coli, and I'm sure of it, right? Like some people are that good clinically, but we don't actually know, right, when we're sending the test. And so, again, in a really fun way, we've been able to fold in things like human factors engineering and behavioral science and now implementation science to kind of answer these questions. So what do I mean specifically? So as Brightstar was sort of like up and rolling, we did a couple things. So first thing, okay, so quick poll. How good do you think a PICU clinician is at predicting the results of a blood culture, right? We send this test like water, right? We're supposed, like sepsis is like so ingrained in our bone marrow, we're constantly thinking about it. How good are we at actually predicting the results? Okay, crummy. We're so good. Okay, so this was like just one little one-off that we did, but we asked people, okay, send a blood culture, don't send a, but I'm not going to tell you like, you know, sort of entirely how to do it. But if you send a blood culture, write down your prediction. We asked everybody to do it. Attending, fellow, nurse, APP, resident, everybody on the team for like 300 cultures, okay? And we were really, really accurate actually at predicting the results. 96% negative predictive value. Obviously, we just waited for the 5 days, like, to, you know, what's the actual answer, right? The culture either is positive or negative at 5 days. Only 2% of those predictions were incorrect, and they were incorrect by overcalling, right? There was literally only one time in like 300 episodes where somebody predicted negative in a child that actually had bacteremia, okay? Which we just thought was really interesting, okay? And so then the other thing we did was baked into Brightstar. So one of the early steps for all the Brightstar sites was something called a work system assessment. And so on Ping, our human factors engineer helped us kind of design a survey that was using the SEEPS 2.0 model, Systems Engineer Initiative for Patient Safety, where you sort of you accept that the sort of like the system that people work in is kind of broken down into different parts that, right, all kind of interact to facilitate an outcome. And so we like use all those kind of categories and asked a whole bunch of questions. It's essentially like doing a baseline assessment of like, what are your practices right now that you would do in any QI project, but just like with like a little bit more like meat on its bones. And so we learned 3 things from all those surveys in our 14 sites. One is that people were like, yeah, this is what we do in our unit right now, but I don't actually think it's like probably the right thing, right? This is how we practice, but it's probably not ideal. 2 was that people were very honest, and I appreciated that they would just reflexively get cultures, right? They don't go see the patients. They maybe look in the chart, maybe don't, but it's basically like you get a phone call, the nurse says, hey, the kid in room 37 is a fever, and you go, okay, I'm gonna order some cultures and antibiotics, and you like move on with your day, right? Head nodding, like, cause like it's not ideal, but like that is real. So people told us that. And what we had sort of seen all along at this point was variability. So variability in terms of people, what they would choose as a blood culture source, how frequently they would repeat it. Would they do surveillance practices, for example, on somebody on ECMO or dialysis or not? So that's what we learned from that. Okay. So here we are at this point, and we're sort of like, okay. So again, like Brightstar's happening. We're like, you know, starting to get data rolling in. But we sort of, okay, we don't think we use this test particularly well. People told us that. We admit we use it reflexively without a lot of pre-test evaluation in highly variable ways, but we're actually like pretty good at predicting when it's going to be negative. So again, it wasn't a planned part of Brightstar, but I'm so happy we did this part. And we sort of said, we can do better than this, guys. So we also happen to have like a captive audience of, right, like 14 sites worth of like really engaged experts also in this topic. Can we come to a consensus about using this test, right? When we should or shouldn't do it in a PICU patient. And so we did this Delphi, a modified Delphi method. If you haven't done it, 10 out of 10, highly recommend. Like we just trapped people in a room for 2 days in Baltimore and just like hashed it out, right? It's really fun to sort of like watch people sort of like how do they like justify the evidence, and how do you reconcile different opinions, and knowing that it is imperfect, right? This is not evidence-based, it's consensus-based, but at least it was something, right? And so what we got out of that was the first consensus-based recommendations for blood culture reduction in critically ill children. And the first kind of standardized guideline, right? Because again, this is like such a simple test that people don't even think you probably need a guideline, but it turns out you probably kind of do. And so we got that published. Okay, and so in terms of those consensus recommendations, we're now doing things with them, including thinking kind of about larger scale dissemination. And I'm really interested in like what kind of implementation level data you might be able to gather that. And that's kind of baked into the pilot study that I'll talk about at the end. Okay, but right? So we like side projects are fun and interesting, but like what actually happened with Bright Star? Okay, what was punchline? So happily, same kind of thing, 33% reduction, very similar to what we had seen kind of along the way. Our primary outcome was blood culture rates in our 14 sites, and there was a big drop there. And then in terms of safety balancing metrics. Okay, so you have to have this table, right? Mortality, readmission, length stay, blah, blah, blah. You have to look at these metrics because people will expect you to. We didn't see any sort of concerning signal that there was a change for the worse in any of those. But this is like not actually all that helpful, right? We didn't think it was enough, honestly, granularity in terms of paying attention to the safety balancing metrics to this. So we also did this. So we developed something we called like a safety event review form. And we asked all of the site leads in our 14 sites to actually audit every single positive blood culture that happened in their PICU after Bright Star launched in their site. And like as much as you can, recognizing like it's in hindsight and it's using just kind of whatever's documented in the EHR, but like look 48 hours before the blood culture, look at vital signs, look at documentation. Was there an opportunity for a blood culture that you can sort of tell from looking at this data where it maybe should have been done but wasn't, right? We're trying to find evidence of delay. And if you thought there was delay, do you think it was actually related to Bright Star, right, the new guidance, or was it delay totally unrelated? Like, yeah, the kid had a fever, but they were down in MRI and we didn't get them up here for 3 hours and that we just sort of did the best we could. That's how it happened, okay? And so there were 793 episodes of positive blood cultures in the Bright Star sites post-implementation, and in 792 of them, there was no concern for delay, which we thought was great. The one time that there was actually was a split of opinion between the ID, I should have said that the site leads for all of the Bright Star was one ID person, one PICU person. And they disagreed with each other about whether there was or wasn't a delay. So we always include that to be transparent, but we were so close to 100%, but we'll take 99. Okay. And then antibiotic use. Okay, so we finally got to look at this. So 11 of the 14 sites were in FIS. So we were able to pull antibiotic use from that data set. And we were really, again, relations on causation, like unclear. But we did see a 13% drop in broad spectrum antibiotic use post-implementation. We only looked at day 3 and later. That was on purpose because this project is not for the like fresh admission, undifferentiated kid, the kid that you just got, that you're actually not sure yet, like what their fever is from, right? We didn't actually think that it was like all that useful for sort of undifferentiated, potentially unstable kids, right? This is really for kids, the sort of like prototypical kid in my mind that benefits from Bright Star is like, the kid that has a documented different source of explanation for their fever, right? A viral infection, something else that has a central line in for whatever other reason that typically in like the days before this, anytime they had a fever, people would go, they have a fever at a central line, therefore they must potentially be bacteremic and I should check. And maybe that's what we tackled a little bit. Okay, so 13% reduction here. And then new initiations of broad spectrum antibiotics is the other outcome metric that we looked at, which I think gets at our hypothesis that if you're sending fewer blood cultures, you're potentially starting fewer rule outs, right? With broad spectrum antibiotics, we saw an 8% drop in that, which we thought was great. And though it ended up in the supplement of this paper, which surprised me a little bit because I thought it was like kind of important, but we also looked at contemporaneous antibiotic use from FIS in PICUs that were not in Bright Star at the same time to just see if antibiotic use was just going down, right? And we just happened to catch this and it wasn't, it went up. So we were very excited by that, but the editors were like, not whatever. Anyway, it's in the supplement. I thought it was cool. So that is what we learned from Bright Star. Okay, we get this question a few times, and I think it wasn't the primary goal, but it's sort of, yeah. Mm-mm. 14 sites did their different thing. Yep. Yes. Yep. So I think a relatively logical question to ask about this is, was there any impact on CLABSI rates when you do this, right? You're sending fewer blood cultures in theory, right? You're sending them, when you actually think it's more likely that they will be positive and not sending them so often when you actually aren't that worried about bacteremia. Is there an impact on CLABSI rates, which is like a very multifactorial, messy thing. I completely admit that as well. So our focus was like, do you get or don't get the blood culture? Does over testing drive false positives or contaminants, right? That like you get a result and now you're stuck with it and you have to do something about it, but it's actually not clinically significant bacteremia at all. So would CLABSI rates be impacted by this? 36% drop across the sites, okay? Which we also thought was interesting. Not a primary outcome metric. Again, like multifactorial, people have, there's a huge amount of work that goes in. I do some of this for the CHOP PICU as well. There's a ton that goes into bundle maintenance and all those sorts of things, but we thought that was interesting. And I just like that the harder you look, the more you find, just sort of like backing up conceptually, right? Like this is potentially what's happening here. And maybe we can actually like improve this sort of other thing if we're better stewards of this test. Okay. So then sustainability started to become interesting to us, right? Because it is like, not easy, but it's like one thing to say, okay, with like a well-funded, highly resourced project, right? And like this was like a high contact project, right? We had monthly calls with all the sites. We did our quarterly sort of surveys. We were collecting data a ton. We're like, really obviously like sort of like nudging this project to the top of their mind as much as we possibly could. When that totally goes away, right? What happened to blood culture rates? So we looked at 2 additional years of data to look at sustainability. And there's a little bit of an uptick, right? As the project ends, which was also sort of good for us. And most of our data collection ended like right in January of 2020. And so then there's a COVID something, but then it goes back down. So 8% higher than the initial post-implementation, but remained 27% lower across the board, even 2 years later, which we thought was like really great, suggesting that like sort of like the culture change had maybe taken root. And then what happened with CLABSI? Like, did that track along with it? And it actually looks like it did too. So again, a little bit of a bump right up at the end of the post-implementation period where the project ended, and then but stayed 28% lower than pre-implementation. We are trying to get micro data from sites to see if this, like, our hypothesis actually holds up. Like, did we actually just have fewer contaminants potentially? And is that what drove CLABSI reduction, or was maybe a part of it? We're still working on that piece, but I think it would be great if we can get that. And then trying to convince the CDC, I think they're going to say yes, to give us contemporaneous PICU CLABSI rate data from non-BrightStar sites. So we can also say, again, was everybody just better, or is it different in our sites? Okay, so now what are we doing, right? So we're like, okay, like I was like, this is great, like the paper's out, like yay. Whew, okay. But now there's just so many interesting questions, I think, about the how, like what was actually happening in all of these units? Like, how did you do the cultural change? Like, what was working? And this is where the implementation of behavioral science stuff is really coming in. So you probably all have, but in case you haven't heard of implementation science, first, it's like the best thing ever and everybody should do it. But essentially, a scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practices and improve the quality and effectiveness of health services. And you're like, that just sounds like QI kind of, or what everybody does. But really the point of implementation science is this. So it takes a decade or longer for a good evidence-based something, right? A test, a treatment, a bundle, whatever it is, thing to go from publication to widespread clinical use. That is called the research to practice gap. And implementation science exists to shorten the research to practice gap, right? It says, okay, you've told me, right, with like you've done a bunch of studies and demonstrated this drug is really important, right, for these people with melanoma, but most people actually aren't really getting this drug that would benefit their melanoma. How do I fix that second half of the problem? It also happily offers rigorous theories and frameworks and models to help you understand how clinicians use something like a test or a treatment, why they do or don't do something, and then how to change their behavior. So I was like, that's what I need. Okay. Second piece of this, and this is sort of like newer material that we're playing around with, and I finally got to take like a real behavioral science course to like dig into this more. But again, probably most of us have heard of this in popular culture, or maybe even in your own work. So the idea here that we have these decisional shortcuts or heuristics, right, that we use all the time during medical decision making, and they're probably helpful and they probably are okay, except potentially if we kind of over rely on them, they can lead us to make errors in judgment. That's cognitive bias. And so there's sort of more and more work happening that it's integrating behavioral economics and healthcare. Who's heard of like a nudge unit? Right. We all know this stuff. Okay. And so we were kind of like, okay, like, is there something to this here? So we have these kind of observations at this point. So one is that, my people, PICU clinicians, we like to do stuff, right? We're not patient people. We don't like to stand there and not do things. We like to do things more than we like to observe, but that has a name, which is commission bias. We also like to do what we're used to doing. We like to provide care. It's sort of like our usual way, the way that we're comfortable doing with that. And that is default bias. And then we get burned by bad cases, right? We remember bad cases and we let that potential case influence the next thing we see that's kind of similar, even if it might not actually be appropriate to sort of make a decision now based on what happened in the past. That's called outcome bias. Okay. And then a couple more conceptual things I think are important. So this idea of loss aversion and prospect theory. Okay, so prospect theory describes how people choose between options and how they estimate the perceived likelihood of different options. And loss aversion is a really big part of prospect theory. And loss aversion is simply this idea, losses loom larger than gains, right? So our behavior is more motivated more by like the worry about a negative outcome than it is by a potential positive outcome, right? So it feels worse to lose $20 than it makes you happy to find $20. That's kind of the idea. And a lot of like life is constructed around this concept, right? Like, you know, you pay for an insurance premium, right? You'll say, okay, like I'm more motivated, right, by the worry of like losing my house if there's a fire than I am, you know, sort of about saying, okay, I'll give up this $100 a month or whatever that I spend. Or like once you get the free, all this like fancy package of all the channels from Comcast, you don't want to give it up, and they know that. Okay. So, but back to this work. So we kind of began to have this hypothesis that is loss aversion actually like driving how we approach diagnostic testing in the PICU, right? Like we don't want to be wrong. We don't want to miss things, especially maybe when somebody is coming in and trying to sort of reduce the use of a test that you're familiar with. Okay. So uncertainty, I think drives a lot of what is happening. I just really like these quotes to just sort of like think about what this means. So at once it struck me what went to form a person of achievement when a person is capable of being in uncertainties, mysteries, doubts without any irritable reaching after fact and reason, right? So it's sort of just like sit with uncertainty, right? Like just live with it. You have to be okay with it to some degree. And then more recently in the New England Journal, same idea, right? The human struggle to live in a grayscale space where uncertainty is rife, a space that is neither black nor white. Our quest for certainty is central to human psychology, however, both guides and misguides us. And I think bringing back to this, one last sort of conceptual like little difference here is the difference between risk and ambiguity. So uncertainty, right, is defined as the decision making in the face of either known probabilities, and that's risk, right? Because sometimes people will say, are you like, is this really loss aversion? Or are you just trying to figure out how risk averse clinicians are? It's not, I don't think it's quite the same because we don't know the probabilities that we're dealing with, right? We're thinking specifically about sepsis in a critically ill kid. Or unknown probabilities, that's ambiguity. And data has demonstrated that people are increasingly loss averse when there's greater uncertainty, specifically when there's greater ambiguity. Okay. And so again, asking like, how do you put these things together? Is loss aversion a driver of over testing behavior for something with a lot of clinical uncertainty, not just uncertainty, ambiguity? Like, is this fever sepsis? Right? There's a lot of ambiguity in that question. Okay. So cool, like things to think about, right? But like, what do you practically do about them? So the answer to any of these things is yes. So what now? So can you decrease the diagnostic uncertainty? Now, we talked about this morning. I'm not going to do that, right? I think there are people doing incredibly important big data analytics, predictive modeling work, right? Somebody may eventually actually give us a predictive model or alert for sepsis that is more useful than the ones we currently have and actually sort of discriminate better, you know, in that first couple hours, right, of the fever, you know, look at sort of whatever pieces of the data are going to be important and actually tell us like this is the patient population to be worried about and this is not. But we don't have that right now. And I don't know when or if we will. Okay, so I can't do that. Can I make PICU clinicians less loss averse? Like, can I manipulate that part of their behavior? Can I both, neither? Like, guys, I don't know, but I'm trying something. So the first thing I did to try to like work on this was, okay, let's explore qualitatively what potentially like the drivers or determinants of overuse are. Like, am I right at all? Is any of this stuff even in there? Or is it something completely different? So I did semi-structured interviews of PICU clinicians in the Bright Star sites kind of as it was wrapping up with the goal of trying to understand drivers of overuse. And I used two tools. One was from implementation science called the CEFR, and the other was behavioral economics. So the CEFR is like kind of like if you're if you've heard of implementation science, you've probably heard of the CFER. It's like this very, very popular framework. It's very, very helpful. But essentially, it helps you sort of systematically assess potential barriers and facilitators, and then guide some strategies for helping to sort of change clinician behavior, or potentially explain some of the outcomes. So I use that. It has a bunch of constructs, which are shown here, to write some of the questions. And then I also explored the potential types of kind of behavioral and cognitive bias that we thought might be present. And then, as you should in qualitative work, like just sort of like hands off, does anything else emerge kind of unsolicited that we haven't thought about? All right, and this is what we learned from those interviews. So several things did map nicely to some of the CFER domains here, like inner setting, individual characteristics, like outer setting. Think that might mean like sepsis guidelines, for example, patient-specific risk factors. Okay, so that was good. And then some of these cognitive biases. So the main three that emerged were outcome bias. So again, allowing a prior event to sort of shape what you do in an independent decision. Default bias, right? Tendency to just sort of maintain the status quo, and loss aversion. Yeah, everybody's like, yep, feels way worse to miss sepsis than it does to gain the benefit of diagnostic stewardship. Okay, so that is what we learned from the interviews. Okay. After that, we then said, okay, we've got a huge amount of like really untapped data right now from Brightstar that we haven't looked at yet. Site diaries, call records, all of this like sort of like serial, they were like our implementation surveys, but it was really like sort of like mini focus groups kind of along the way with all of the sites. So we said, okay, let's look at what people did in Brightstar. What strategy, or maybe combination of strategies, may have actually been most effective for blood culture reduction? So what did our top 3 sites do? Was it different than what the bottom 3 sites did? And did any of them happen to potentially actually be successful because they were targeting determinants of overuse? We didn't do it like thoughtfully at the time, but like maybe we can look and see if like that was kind of happening. And then use all that and sort of say, okay, like if that is happening, and then how do you target default bias? How do you target loss aversion? What do you do next? So that's what this new pilot is hopefully is working on. So this is Libra. Actually, UCSF PICU is a site. Thank you. And so at this point, we sort of said, okay, Brightstar had answered like the if questions, right? Like if you could actually reduce cultures, if it had an impact on antibiotics, but we didn't really know how we had done this. And so Libra is a hybrid pilot trial that's exploring kind of what are the optimal implementation strategies for safe and sustained blood culture reduction in critically ill children. So hybrid design, this is I think an incredibly important and efficient thing out of implementation science. So what it allows you to do is look simultaneously at clinical outcomes, the things that you would expect, right? Typical sort of efficacy or effectiveness outcomes. So for us, that would be like blood culture rates, the safety metrics, antibiotics, again, if we can pull it. But also concurrently, you look at implementation outcomes. Totally different words, different concepts, entirely different stuff. This is things like the acceptability of the intervention, the feasibility, the appropriateness, the level of fidelity, right? Like how much are people actually like adhering to the strategy that you're trying to get them to do? You look at them at the same time, though, that's a nice, efficient design. And the reason to do this is like, we're sort of still interested, I think, in demonstrating that this works in different types of units and in collecting ongoing safety data, because I think that's still really important, but concurrently gathering data on how to do this most effectively. And so just like more of a, if you're a visual person, like how do you think of like hybrid designs? And so a hybrid one is really mostly still focusing on the clinical impact of whatever you're doing, but kind of explores, for example, context, like maybe barriers and facilitators to implementation. That's a hybrid one. A hybrid two, which I think Libra is, where you're sort of together studying the effectiveness of something, but also maybe the feasibility or the impact of specific strategies. So you sort of need to have like strategies in mind that you want to explore and analyze if you're doing a hybrid two. And finally, a hybrid three collects clinical effectiveness data just kind of in the background, but really is entirely focused on the impact of an implementation strategy. Okay. So Libra is 8 new PICUs. Everybody kind of gets this core pre-implementation package, this sort of series of steps that is essentially what we had done through Brightstar, that we sort of is a framework that we think works pretty well. But then they got randomized to one of 2 different sort of site level strategies. So 4 and 4, and they were behavioral interventions targeting different determinants of overuse. So like from all the interview data and everything, we sort of picked 2 determinants of overuse, and then half of Libra is targeting one and half of Libra is targeting the other. And then we're going to compare the clinical outcomes and the implementation outcomes throughout the process and sort of see if we can learn anything useful about strategies. Okay.
Can I ask a question? Are you using the algorithm process
Yes. So that, thank you. That for some reason didn't make it into a slide, but yes. So what we actually did differently this time than we had done with Brightstar originally was we took the consensus recommendations. I spent some time making them because they were like, you know, like a paper, but it wasn't like a super usable like actual like tool. So we spent some time turning those into like a clinical tool. The Libra checklist tool is what it's called, and I've given it to all the sites. They are still free to adapt it as they want to. And I've just asked them to send me every version that they make so I can understand what changes they're making and how. It's actually already some of the sites have like changed it, not the content so much, but like formatting and whatever, changed it a lot. And some sites are like, yep, I'm just going to use this exactly as is. The hope as like a nice other outcome out of Libra will be that we'll have like a really well like road tested clinical tool by the end of this, with like 8 sites having like sort of said yeah, like this is good, this is bad, I changed this, I didn't like this, whatever, and use that in the next phase of work, hopefully sort of say like, now we've actually spent some time trying to like harmonize what we think the actual clinical recommendations should be in a nice format that's hopefully usable, ultimately hopefully integrating into EMRs in some fashion for the next phase of the work. But yes. Um,
Professional practice, you know, in the Brightstar, everybody has their own thing in it, but now you're like, this is the national consensus thing, so I'm gonna help move people to get you to think that this is
yeah.
something that my I'm gonna do it.
Yeah, at least, yeah, exactly. So that the new default practice is hopefully like the ideal one, right? That is like being mindful of overuse and reflects consensus at least on how to reduce things safely. Yeah. Yeah. Um, so that's where everything is at the moment. I think what we've learned about it is that, so yes, you can do multi-site collaborative work and implement diagnostic stewardship, even in sort of a clinical entity that's like as complicated sort of psychologically and clinically as sepsis. What we've done here, which is really a blend of QI and implementation science and behavioral science, could probably be translated to any practice, right? This is like a very specific example of blood culture, but like doesn't have to be constrained to that at all. Using our Delphi, we created the first ever consensus recommendations, which I think are an important part of dissemination. And then the first ever association between a stewardship intervention and for blood cultures and antibiotic reduction is what we found. Lots of things coming around the corner now, which is trying to determine ideal strategies, which is Libra. We have this, I think, is hopefully going to be baked into the R that I need to start writing like immediately, but is really interested in, now that we've like thought so much about how and process and strategies, like what can you strip down that's actually like the core essential elements of how you do this, right? That like anybody in almost any pick you could actually like pick up and do. And so that some version of playing around with that, maybe in 3 arms that like each have like a downgrading level of intensity, is probably going to be what the next project is. And then ultimately by the end of that, hopefully we'll have this toolkit that's like, this is the stuff, right? Here's the stuff. Brightstar 2 happened after Brightstar 1, which was the same exact thing, but for respiratory cultures, another like terribly uninformative and massively overused test. And so that's just about wrapping up, and we're looking at prelim data for that now, which like looks pretty good so far. We don't have antibiotics yet though. And then very exciting is Brightstar UK. So we were approached by a PICU in Liverpool, England, called Alder Hay, that wants to work on this with us. And they kind of came at it from a very different lens and had a lot of questions about like potential cost savings and things, which we're working on looking at. But we've been working with them for a few months. They just launched in February 2024, and we're going in like 2 weeks for our first site visit there. So that will be fun for a lot of reasons. And then thank you to you guys for letting me come and speak with you. It's been a super fun day. Thank you to LDI for years of mentorship and support. My entire team here, Chris Bonafide, Renata Vedas, who taught me kind of everything I know about implementation science, all the sites and site teams for both Brightstar and Libra, my boss for letting me do this sort of like atypical, not entirely sure what you're doing, but you seem to be doing okay kind of work, and for letting me have the freedom to do that. And then these wonderful people, and my husband for once again holding down the fort while of course the kids are sick while I'm gone. And that's all I have.
So, so for questions in the room, we need to use a microphone so people online can hear. And then for people online, if they can put your name in the chat to talk. Is there any? I'm gonna go with the prompts here.
Thank you so much. This was so informative, and I can see how it resonates with many other domains that are not necessarily the one you're looking into. I have one really factual question. I'm sorry, I think I missed it at the beginning because I wasn't here, and then I have a more analytic question. So the factual is, I'm assuming that the protocol is that you get a blood culture, you wait 5 days or whatever time you need, and then you make a decision on antibiotic use, right? Like, because what I have seen with my child is that you do a blood culture, but while we're waiting, because this is life-threatening and we are
Yep.
in a medical emergency, I'm going to give you antibiotics now.
Completely, yes. So that is ordering blood cultures and starting antibiotics is a very, very linked action. So most I think pediatricians were trained, and the way I sort of see all my colleagues practice is if you decided to send a blood culture, it meant that you were worried enough about bacteremia that you were going to send the culture. Therefore, if you sent the test, you're going to pair it with antibiotics. So mostly those two things are happening at the same time. And that's why we were wondering, if we don't do the first thing so often, are we decreasing the antibiotic use just because they're such linked behaviors? Yeah.
Perfect, perfect. The second question is, I find that this is so informative, so rich, and I can see the whole process. And I understand you mentioned a couple of times the word stakeholder. I wonder about parents, people like us, what is the influence on clinicians' decisions? Have you been able to grasp anything of that? Because I can assume that we are very pushy, and I have been told so.
It's a really, really good question. So full disclosure, so my original interview plan, which was submitted before COVID, was to do a series of interviews with parents in the PICU, both parents of like healthy kids experiencing an acute illness, and also the parents of, I think, very important group, chronically ill children who come in and out of the ICU a lot. That died during COVID because we barely let parents, it was actually awful, but we barely let anybody be at the bedside. And so I had like no practical way to sort of actually find those people. And they sort of said, like, don't even, it's just like, what is like a COVID casualty? I still think it's really important. When I did my interviews with clinicians, it's not the same, but I did ask, again, explore with the clinicians, especially the bedside nurses, what they thought about parent opinions and parent influences, and like sort of did they think that parents were like potentially somebody that would like drive behavior one way or the other. And some of them said yes. It wasn't like the super strong theme that emerged, but it's like I wasn't asking the right people. I asked, but I still think I actually like need to tackle this a little bit with parents. It seems it's interesting because I don't know, my own like just totally anecdotal opinion on this would be, I don't, other than parents like very medically savvy parents who are there all the time, most parents I don't think sort of like think about the blood culture test as much as they might think about the antibiotic piece, right? Parents, I think, have certainly in my clinical experience have strong opinions one way or the other about what treatment are you doing to my child. But it's not that they don't ask questions about the diagnostic workup, but they sort of just say like, oh, you're doing blood work in a sort of general, non-specific way. They may not sort of like say like, you're testing for the presence of bacteria in the blood, and I have a strong opinion about that. But a good question that we'll be able to figure out how to sort of get the parent perspective at some point, if we can.
Hi, such great work, so much fun to hear about, and it's so clinically relevant. The one thing that I was thinking about, I actually, in listening to your story, I was actually thinking,
The end part right now is like, why haven't we got it better? So let's talk about all the barriers in that way. But I think it's probably helpful to also like, why did this work? Because a lot of why are like major change is not have happened, and you still like people ready,
Wanting.
they want it.
Yeah.
So think about this. There's some positive part of it that doesn't have to think, but like clearly we're doing this. We all agree we're doing it. We just want to figure out how to do this. You might just not have the same level of that.
Yeah.
Help like try to get that as you can see more and the phrase in mind that making the right.
Yeah.
And so this, I feel like, sort of helps with that, not only because you get to do that,
Mm-hmm.
but also because you feel like
Yes. Yeah. No, I think it's a it's a very important point. Like people were, there certainly are some people who like don't think this is a good idea, don't think it's important, like don't want to change their practices. But most people are like, when you start talking about it, like, yeah, we probably do like too much of that, right? Everybody sort of can have a story of like, and but most people I think just also weren't paying all that much attention, right? It's such a low level thing on your list of priorities, like whether you're the ICU resident or the attending, like, you just aren't actually, when you tell people like, did you know that you sent like 42,000 blood cultures, right? And then they're like, oh, sorry, but they just are thinking mostly about other things. So yeah, I think this, like, there wasn't a lot of, there was some, I'll put them over here, but most people didn't have like a lot of like conceptual pushback. Like, I don't agree. I don't think this is important. It was just kind of like, hey, I haven't really like thought too much about it. And then we came along and said, here, we'll help you do that. I think exactly to your point, we sort of made it easy. But yeah, other things, is it going to be a totally different like ball of wax if we do imaging, stewardship, or other lab tests, right? And sort of how do we potentially tackle those things? The respiratory culture one was really interesting because I thought people would care less, would object less to sending fewer respiratory cultures, because like if you miss like a VAI for like a day, who cares, right? Nothing bad is going to happen, right? It's totally different clinically than if you miss 24 hours of bacteremia. That may have a catastrophic outcome, but people really like them. People they believe that the white count means something in a tracheal aspirate, and guys, it just doesn't mean anything. But whether it's like, because like now you're really dismantling like the pan culture concept, and people get a little bit nervous about that, or whatever it is. So that may, again, data still coming in, I shouldn't like speak too much to what we see, but we actually may end up seeing a smaller drop in that, even though that test is so massively overused, and I thought would be conceptually simpler for people because it's less scary. So I just like interesting differences that we're seeing there. Yeah.